Our ancestors, on average, were consuming 15 grams of salt per day. How do you explain double the salt and less hypertension if salt is the reason for the hypertension?
I mean, you can be hyperreactor to one stressors, but not to the other stressors, and not to overall blood pressure variability, which is probably generated by a number of factors well beyond just the emotional response to stimuli.
We also know that there's a dipping of blood pressure at night, and this can be lost. So controlling blood pressure is extremely, extremely important, particularly in diabetic patients. Hypertension is a huge problem for diabetic patients in terms of progression of cardiovascular disease and progression of kidney disease.
I think it begins with the kidney. And I've written a lot about this. We think that it begins with...
Hypertension is a very complicated disease. So many factors involved, so many hormones, so many
Indeed.
organs. To the best of with your endocrinological experience and as a neuroscientist, what is the best explanation for hypertension?
I couldn't agree more. Hypertension is very complex. I'm not going to argue that. There are many things that go into hypertension. Think of it this way. In 1974, when I was, getting close to starting medical school, you would go to the doctor and you'd have hypertension, and your doctor would give you a thiazide diuretic, a low salt diet, and pray. That's all there was. Okay? A diuretic, a low salt diet, and pray. And we didn't do very well. A lot of stroke.
Yes.
Okay? Today, we have about 20 different mechanisms for the development of hypertension. We have about 85 to 100 different drugs that take advantage of these various physiologic symptoms. All true. Yet we still have a problem with hypertension. It hasn't actually solved the problem, has it? And so the question is, what is that? Now, there are specific syndromes of hypertension that are unique, like, for instance, the Goldblatt kidney, high renin hypertension, like aldosterone secreting tumors, low renin hypertension, okay, and many, many things in between. But this does not really solve the pandemic of idiopathic, meaning we don't know what causes it, hypertension. And I think that's what you're referring to today, is this idiopathic hypertension. So what do you do when you see a patient who has hypertension and there doesn't seem to be any obvious reason?
Mm-hmm.
What is that about? Well, the standard thing to do would to be put them on an ACE inhibitor, like captopril or lisinopril, and also, restrict their sodium intake and see if their blood pressure would go down. And usually it does, but it usually then comes back up again, and it's still a bit of a problem. So the question is, what's going on with these people? And the short answer is, I don't know. Okay, but I have some ideas. I have some clues. Okay, now, the medical profession will tell you that salt is really a major driver of hypertension. They will tell you that we are consuming 6.9 grams of salt per day on average.
Mm-hmm.
And we only need 1,500 milligrams, 1.5 grams, and that an upper limit of salt consumption should be about 2.3 grams.
Mm-hmm.
So about 1/3 of what we are consuming. Now, I'll tell you, it is very hard to get from 6.9 grams of salt down to 2.3 grams of salt. That is very hard to do because the food tastes crappy when you take that much salt out of it. And so people don't do it. Here's the conundrum, though. Here's the problem with this. Our ancestors, before refrigeration, before the 1920s, they would go in fishing boats and fishing trawlers from, northern New England or, out into the Atlantic Ocean. And they would fish, and they would catch big fish, and they'd be out for months at a time. And then they would have to bring the fish back and sell it. All right. Now, they didn't have refrigeration. How did they keep the fish fresh? They didn't have a bunch of tanks on the ship, you know, uh, where the fish were swimming around inside the tanks. How did they keep these dead fish from spoiling? They packed them in salt.
Mm-hmm.
They salt cured them. Okay. So our ancestors, on average, were consuming 15 grams of salt per day. 15 grams. Okay. We're consuming 6.9. We're consuming less than 1/2 the salt that our ancestors consumed. And they did not have a problem with hypertension. So how do you explain double the salt and less hypertension if salt is the reason for the hypertension? This is a conundrum. And the reason is because it is true that salt can increase blood volume if you're holding on to it, if you're holding on to the sodium at the level of the kidney and keeping it in the bloodstream, then by definition, you're holding on to water, in which case, then you're increasing the blood volume, in which case you're increasing the blood pressure. Okay? All of those things are true, provided your kidney cannot excrete the salt. The point is that up till 1920, our kidneys were excreting the salt. Now they're not. What happened to our kidneys that all of a sudden now we can't excrete a salt load?
Insulin.
That's the real question. That is the question that matters here. Okay, so what causes sodium retention at the level of the kidney? That is the question we're asking. And the answer is insulin. The hormone insulin causes sodium retention at the level of the kidney by altering proximal tubular function. That's how this works. Insulin increases sodium retention and doesn't allow sodium excretion. So when your insulin is high, you retain salt. Now, why it does this, I don't know, but it does. So our serum insulin, our fasting insulin level used to be less than 2 or 3, certainly less than 5, when we used to be insulin sensitive. Today, everyone is insulin resistant, and I can prove it because 40% of America is pre-diabetic and 10%, 11% are diabetic. Okay, they all have high insulin. Now, the insulin doesn't work, but it's very high, and it's working at the kidney to cause that retention of salt. And the question, of course, is why is everyone insulin resistant? Because when you're insulin resistant, you can't excrete that free sodium load. That is the question. I mean, what caused that insulin resistance, that hyperinsulinemia, to cause the sodium retention? And the short answer there, sugar. Sugar. Sugar causes insulin resistance. At the level of the liver, the pancreas recognizes the insulin resistance at the liver, has to make more insulin to make the liver do its job through mass action, increases the levels of insulin in the blood, and now you have fasting hyperinsulinemia. And then that hyperinsulinemia is working at the level of the kidney to retain sodium. And now you have hypertension.
Mm-hmm.
There are studies that are multivariate analyses of the effects of sugar versus salt on reduction in hypertension. It turns out the sugar is more important than the salt. And when we get the sugar down, we get the blood pressure down. In addition, sugar, fructose, at the level of the liver causes ATP depletion because the fructose has to be phosphorylated to fructose 1-phosphate. That causes the ATP in the liver cell to give up a phosphate to do that phosphorylation. So the ATP goes to ADP, the ADP goes to AMP, the AMP goes to IMP, inositol monophosphate, and then the IMP ends up as uric acid. And uric acid is the endogenous inhibitor of the enzyme in your blood vessels, endothelial nitric oxide synthase, or eNOS. And so nitric oxide is your endogenous blood pressure lowerer. So nitric oxide reduces your blood pressure. But if you can't make nitric oxide, then your blood pressure goes up. Well, this metabolite of sugar ends up leading to reductions in nitric oxide and therefore increased blood pressure. So in fact, fructose does it two ways. It does it at the insulin resistance level at the kidney, and it does it at the uric acid level at the artery. Here's the problem with medication. You can lower blood pressure with medication.
Mm-hmm.
You can. All right. I mean, there are so many antihypertensives out there, it's not even funny. You can get blood pressure down with medication with side effects. Almost all of them have some manifestation of side effects. And the question is, are you really solving the problem? All right. There are two problems with high blood pressure. Number one is the blood pressure itself. And number two is the pathophysiologic mechanism that led to the high blood pressure. So when you give a medicine that lowers blood pressure, you're solving the high blood pressure, and it's only good as long as you take it. But you're not actually solving the pathophysiologic mechanism that drove the hypertension in the first place. That's still going on. So if it's a problem of endothelin, the endothelin is still a problem. It's not like reducing the blood pressure changed your endothelin levels. It didn't. Okay. If you bring your blood pressure down, it's not like that improved your kidney function.
Mm-hmm.
Your kidney function is still going down the tubes. Okay. So it band-aids the problem. It doesn't fix the problem. It's better than leaving it alone,
Mm-hmm.
but it's not actually fixing the problem. You have to work upstream of a problem in order to fix a problem. And with antihypertensives, we're not actually fixing the problem. We're fixing the symptom of the problem.
Mm-hmm. And you mentioned in metabolical, if your blood pressure rises at the doctor's office above 130 over 90 at the first measurement, and then goes down at the second, this is often referred to as white coat syndrome.
Right.
And usually passed out by the doctor as benign. It is not.
That's right.
Yes, and
What it's
having
saying,
is a sign
Right.
of active sympathetic nervous system.
right. What it's
And
saying is that your sympathetic nervous system is on high alert. It actually part of that amygdala response that we talked about at the very beginning.
yes,
Okay. And, over time, that can become a problem. And so patients who have white coat hypertension are at risk for developing real hypertension later in life.
why would someone have overactive sympathetic nervous system?
Oh, dear. That is one of the most important questions in all of society. Why would anybody have an overactive sympathetic nervous system? And the answer is because your amygdala is not working right. And why is your amygdala not working right? Well, there are 4 brakes on the amygdala. Prefrontal cortex, which is called reasoning. Hippocampus, which is called memory. Afferent vagus nerve, which we call interoception or gut feeling. And finally, oxytocin, which we call safety. So those are the 4 brakes on the amygdala. Reasoning, memory, interoception, safety. Today, in our society, all 4 of those are broken. Now, they're broken in different ways for different reasons, but they're all broken. And so there is no brake on the amygdala. And when there's no brake on the amygdala, the information coming in from the outside world, the stimulus, which should be turned into negative reinforcement, turned into, oh, I should avoid that, turns it into chronic stress, like I'm going to die. And that raises that sympathetic nervous system. That raises the blood pressure. That raises the cortisol. And that puts you at risk for systemic health diseases later on. And we're seeing it all over the world. The most obvious place, a study that was done that demonstrated this was the Whitehall 2 study in the UK. Demonstrated that, in fact, chronic disease had very little to do with obesity, it had more to do with um, uh, uh, anxiety and unhappiness and
And can
stress.
Mhm. And can that spike in blood pressure causes vessel damage and organ damage?
Absolutely. So every spike in blood pressure changes endothelin levels inside the blood vessels, which basically put them at risk for damage later on.
Uh-huh.
In addition, high glucose acts like little, grains of sand in terms of inflammation within, arterioles and capillaries, and can do damage as well. So yes, those spikes in blood pressure that occur, just due to regular living, ultimately take their toll. It takes a while, but they do take their toll.
Uh-huh. And yet there is no guidelines for medication for these individuals.
For an overactive sympathetic nervous system, we don't have any drugs for that. No, we don't have any drug for that. There's no drug on the planet for that.
And what do you
Okay.
recommend for these people?
Well, that's a good question. I'm actually writing a book about that right now
Yes.
called Freeing the Hostage Brain. It'll be out in about 2 years to address this exact question. It's part of the reason why I'm, focused on it. And the issue is that this is a societal issue. This is not a medical issue. And, we used to be able to manage our stresses, and now we are not. And the only way to fix it is to fix the 4 breaks: the reasoning, the memory, the interception, the safety. And each of these are a problem at different, due to different stimuli, different problems in our environment. When it comes to safety, usually that's an epigenetic problem that relates back to childhood, like adverse childhood experiences. Interception may be due to food, like, for instance, serotonin levels in the gut that ultimately reach the brain. Tryptophan levels, that get metabolized in the liver to a substance called kyuranine, which then gets turned into quinolinic acid, which causes its own damage instead of it going to the brain and being turned into serotonin, where it can do some good. The hippocampus is slowly but surely shriveling away under the weight of cortisol, in part because the hippocampus is the most energy intensive part of the brain, and cortisol makes you need more energy and you can't supply it. And so the hippocampus is involuting and becoming smaller, and the amygdala gets bigger. And finally, the prefrontal cortex. And the prefrontal cortex is your reasoning. And basically, dopamine puts that to sleep. Basically makes it non-functional. I want it now. I can't delay. Basically, prefrontal cortex is all about cognitive inhibition, being able to say, I can avoid that stimulus. But when your PFC doesn't work, then you can't avoid it. And so that's what we're seeing. We're basically seeing a world of depression and addiction. And it's all because of this dysfunctional amygdala.
Hypertension is a very complicated disease, white coat syndrome, and there is white
Yeah.
coat syndrome also from day to day. Does that spike in blood pressure causes endothelial damage or organ damage?
And the answer to that is yes. Okay. So any elevation in the blood pressure is going to be deleterious. Okay. And people respond differently to stress. If every day of my life, I'm under incredible stress. And if that drove my blood pressure up, I probably would have died a long time ago. But my blood pressure actually is it's like textbook perfect, 120 over 80. And I assure you that my day is very stressful. And then there are other people who even modest stress can really elevate their blood pressure. And that on a long-term basis will have a negative impact. And as you said, blood pressure and hypertension is very complicated. There are many factors that are involved. And we now have good instruments for doing home blood pressure monitoring. So we also know that there's a dipping of blood pressure at night, and this can be lost. So there are subtle changes in blood pressure that can predispose to atherosclerotic cardiovascular disease. So controlling blood pressure is extremely, extremely important, particularly in diabetic patients. Hypertension is a huge problem for diabetic patients in terms of progression of cardiovascular disease and progression of kidney disease. So it is very important that we really keep the blood pressure as close to normal as possible, meaning 120 to 130 over 80. That can be difficult. It can be done, however, because we do have a large number of antihypertensive drugs that can be used in combination. And if you do that, you can effectively get the blood pressure controlled in the majority of patients. One of the things that tends to get forgotten is diuretics. It's very difficult to control blood pressure unless you put people into a little bit of negative salt and water balance. So these kind of people with, a mild diuretic, maybe with a calcium channel blocker, can do really quite well. The key thing is to monitor the blood pressure in whatever you use to lower the blood pressure. You need to see, is it working? And so I recommend home blood pressure monitoring, particularly when you're starting medications in patients, so you can follow whether you're getting the kind of response you're not. Yeah, you can check your blood pressure 2 or 3 times during the day. That would be sort of second choice. But if you are monitoring it throughout the course of the day, you get a much better picture of what's going on. And you also learn what are the factors in life that stress you. And so if there are certain environments or situations which you see are particularly stressful, and you can see they jack your blood pressure up, then I think it's important to try to avoid those stressful situations. Although sometimes in the jobs that we have, it's not so easy to avoid these kind of stressful situations.
Too many people have salt sensitivity, and that also causes high blood pressure. Should these people limit their salt completely, and that will improve the kidney function and blood pressure?
Yeah, so it's easy to tell people to cut salt out of their diet, but salt is everywhere in the diet, so it's not so easy to do. But yes, having the patient meet with the dietitian in reviewing, because sometimes patients are taking foods that have a lot of salt in it, and they don't know it. So to the extent that you can cut down on dietary salt, that's important. But as I mentioned just a few moments ago, people tend to forget diuretics. And it's difficult really to control blood pressure unless you put people into a little bit of negative sodium balance. And that's best done with a diuretic. So in the treatment of hypertension, I think it's very beneficial to have a diuretic in combination with what other antihypertensive drug you happen to like.
Well, way back in the 1940s, actually, maybe even earlier, someone did an arterial catheterization in normal people and found that during the course of a day, almost everybody hits a blood pressure of 150 at least once, the systolic. So we know that blood pressure variability really exists and blood pressure goes up and down. But, in general, people with hypertension are going to have um, it goes through a phase. Really, there's sort of this phase called borderline hypertension where they're intermittently hypertensive, and some of them will have white coat hypertension, for example, when they get nervous, their blood pressure will go up, or when they're seeing a doctor, and then it becomes more persistent. What we usually do is, the first reading, if it's just mild elevation, what we'll do is we'll do, 24-hour ambulatory blood pressure monitoring, or we'll have them take the blood pressure at multiple times. I mean, at different times of the day. What I do is I give them a blood pressure cuff. I say, measure your blood pressure and record it in this notebook and record the time. And I want you to do some in the morning. I want you to do some in the afternoon. I want you to do some in the evening. I want you to do some while you're resting and some when you just got back from exercising, et cetera, et cetera. I want to see the whole kind of picture. But there is data showing that borderline hypertension, where your blood pressure just goes up and comes down, even that is associated with an increased risk. So if
Yes.
if it's once a week elevation of blood pressure to 150 or 160, I'm not going to be bothered by that. But if you're having multiple blood pressure measurements that are elevated, even if it would be borderline, I view that as you're moving into the phase of, there's a high risk you're going to develop persistent hypertension, and it's probably better to treat it. And now what's happening is more and more studies show that people do better with lower and lower blood pressure. There is a region where if you drop the diastolic too low, you're not filling the coronaries very well. But for most people, it'd be great to have blood pressures of 130 over 80, especially if you have kidney disease. And you have to be kind of careful when you get older, like if you're 75 or if you're older, you often want to have a slightly higher blood pressure because they can't auto-regulate as well. So if you make their blood pressure 110 over 70, which a 25-year-old is perfect with, if you're 75 and you're 110 over 70, just a little bit of dehydration can plummet your blood pressure and you can become symptomatic. So you often with people who are a little bit more fragile, you're a little bit more forgiving on what your blood pressure goals are. But yeah, I would say, repeating the measurements, not to be too alarmed. If your blood pressure is really high, if you tell me it's 220 over 120, you need to come to the ER and there is actually, you need to be evaluated right away. There's some people who have kind of a 200 over 210 over 170, 150 or something will have no symptoms. And they don't have any papilledema. They don't have protein in the urine. They don't have any symptoms at all. They don't have any risk factors or history of coronary artery disease. And that's the one type of patient where you could treat as an outpatient if you have them come back like every 2 days or something. And you can try to bring the blood pressure down. But if they have any kind of evidence of target organ damage, they had to get admitted to the hospital.
And when you say 130 systolic, you're talking about home readings or office readings. And how do you take the average out of 10 readings, or you average it out, or you're talking about the highest reading?
Oh, that's a tough one. I usually am talking about clinic blood pressures, but if you're doing home blood pressure monitoring, I'll view that sort of like a clinic blood pressure. If I'm doing telemetry, 24-hour ambulatory, I'll follow the how they do the analysis, which is to kind of do multiple measurements, and they'll come up with an assessment of what percentage of time you are above the goal. I tend to try to get blood pressures to 130 over 80. That's 140 over 90 was the historic level of hypertension, and it's kind of moving more to 130 over 80.
Yeah, the thing,
Especially if kidney disease.
yeah, the thing is there are so many people with borderline hypertension. I even believe that white coat hypertension is pre-hypertension. And
Yes, it is. I do too.
yes, and they, I think that hypertension develops the same way that diabetes developed, that the blood sugar will spike and then go back to rest, the same way it will spike and then come back
That's a
to,
beautiful analogy, Fitz.
yes, yes,
That's a beautiful analogy. That's really true.
yes. And then maybe one day it will go up and will never come down, and then it will become full-on hypertension.
Agree with you. There was a study actually that showed that 75% of people with white coat hypertension will be persistently hypertensive after 5 years. There was
Yes,
one study. Of course, there are probably other studies that didn't show quite that dramatic
yeah.
change, but
I
we definitely know that it's it's like metabolic syndrome. Metabolic syndrome is associated with elevated blood pressure, but not a hypertensive,
Mhm.
theoretically. It's just mildly elevated. Nowadays, the new definitions that might actually be called hypertension.
Yes, and even I had Dr. Giuseppe, who was the former president of the European Society, and he did a study called the Pamela study, and they showed that white coat hypertension develop organ damage and
Yeah,
endothelial damage.
exactly.
Yeah, not as much as hypertension, but not as normal or
Absolutely.
baseline. Mhm.
Yeah, it's really true. I've always uh, not been like a lot of physicians say, oh, you have white coat hypertension. Don't worry about it. I run into friends who say, I have white coat hypertension. I say, no, take care. You probably should be on a blood pressure medicine,
Mhm.
because uh, if you blood pressure's high in the doctor's office, it's probably high other times of the day
Yes, exactly.
when
Yes.
you're a little bit perturbed, and like when a person arrives, oftentimes that first blood pressure
Yeah.
measurement is high. We usually wait 10 till they've been resting 10 minutes. But I find that if the blood pressure is really high when they come in, I think that they are probably doing that every day whenever they walk
Yes.
around.
And working and
It's
driving.
Yeah, working and driving. I mean, the world is
Stressful.
anxiety producing, right? Especially these days.
Yes.
If your stress drives your blood pressure up every time you watch the news, you're gonna have high blood pressure. So yeah, I would say, um, you know, view it as a risk factor. And when you see borderline hypertension, look for, are you eating too much salt? Are you eating too much sugar? Are you eating too much carbs? Are you not exercising enough? And
Mhm.
all those kinds of things. Are you developing metabolic syndrome? Or and jump on it early.
Yes. And when you're,
Don't say, "Oh, don't worry, it's white coat."
that's the that's the issue,
I'm
right?
glad you agree with me, and it sounds like the other experts do too.
Yes. And when you say 130 over 80, are we talking about the average of the whole day? What if it's normal at home and then it's, if we put them on 24-hour blood pressure machine and it's 120 over 80 or even below, and then they have very high variability, it tends to spike. At those situations, do you
You,
medicate them? Do you?
yeah, you know what I like to do? I like to use inhibitors of the renin-angiotensin system, losartan, because it blocks sympathetic activation to some extent. It's not like a beta blocker, but it actually has blocks CNS sympathetic activation, and it improves endothelial function. It's usually very well tolerated, and like an angiotensin receptor blocker, like losartan, or an ACE inhibitor like lisinopril. But if you just put a small dose on, there's like no side effects, but it kind of takes that edge off, the and I feel better if I mean, it's true if they have an ambulatory that says 120 over 80 is their average blood pressure, but every time they see me it's 150 over 100. um I would put them on a I would personally put them on an ACE inhibitor or a losartan, but low dose, make sure there's no side effects, and see if that helps with that.
Yes. And every time it's,
What do you do? Do you do something similar, or what do you do?
yes, I mean, if there is an organ damage, then that's evidence to
Oh
treat. I
yeah, for
mean,
sure.
yes, and but the thing is, if they don't have organ damage, then it gets tricky. So you put them, try fix it little bit with the lifestyle and see how it works.
Yeah, lifestyle. Do a lifestyle first.
Mm.
I mean, like they're not exercising or things like that.
The-
But most people are going to continue with their lifestyle,
yes,
despite what you tell them.
exactly.
But yeah,
The-
so yeah, it all depends. To me, there's not a great cost with taking 2.5 milligrams of lisinopril or 25 milligrams of losartan or something. They're now generic and they're and there was this guy Leon Fine. I don't know if you knew him. He was this physician scientist from Puerto Rico and Ponce de Leon University, and he would do all these experiments with mice. And he would take mice and he would put them on low dose ACE inhibitor or low dose ARBs. And he found that instead of, normally a mouse or a rat lives at the maximally 2.5, 3 years. That's their
yes,
lifespan. But he found that their lifespan was longer if they took these drugs. And he found that they had less end organ damage
yeah,
as they got old, because as animals age, they start getting some end organ damage. And so he became a big advocate that low dose ACE and low dose ARBs might be good theoretically for everybody, but he did
yes.
never really said that. But it was the implication from his work that it can block the development of microvascular disease and arterial sclerosis and aging associated injury to the kidneys and so forth. But you know, I'm not advocating people to just take ACE or ARBs because you shouldn't do that from just a mouse study. But I do think that if your blood pressure's labile, and every time you go to see the doctor, your blood pressure's high, um, my belief is that you probably have this problem more than just in the doctor's office. And even if you know, other things are saying the blood pressure is normal, if the blood pressure is elevated every time I see you, I'm going to probably want to put you on something that has very little side effects and that can improve endothelial function and lower blood pressure.
And when do you lean little
That
bit,
puts you into that group of drugs.
and when do you lean more on medication once it starts to go above 140 over 90 or?
Yeah, yeah. I mean, the very best is just reduce if they're eating a lot of sugar and salt. We did a study in people, and this is actually sort of interesting. We did a study in people with Mehmet Kanbey, who's a physician from Istanbul. This guy is a wonderful physician, and he does spectacular research. And when I say we, what really is, he did this research, but we did it together because I helped design the study. But basically, he gave soup to individuals in which it was lentil soup, and he could add salt to it with the soup sort of masking how much salt was in there. So he could make this bowl with like 3 grams of salt, which is like really salty. And if he gave it to people, their blood pressure goes up immediately. And he also found that if he gave a soft drink or apple juice, the blood pressure goes up within minutes. I mean, it really goes up. And then he showed that was associated with the salt, with an increased salt in the blood, concentration in the blood. And with the sugar, it actually increases the osmolarity too. Interesting. And what he found was that if he gave water with the soup, he could block the blood pressure response. And published it. We have 2 papers actually. And so we've gone on and we really feel that salt and sugar are both driving blood pressure. Salt's been well known for a long time, and it really is true in people who are sensitive to salt. Some people are less sensitive to salt, but a lot of it is how you eat it. If you eat the salt fast so that you get thirsty, your salt concentration will go up high enough to actually activate this fructose pathway. And then if you're eating juice or drinking it, I mean, drinking apple juice, so you get a big slug, you get this big blood pressure rise. So if someone comes to see me, you're exactly right. You should say reduce salt, reduce sugar, drink more water, and come back and let's check you again.
Yes.
But most people don't really change what they do. You can talk to them. Most of them will, and so if you get into the situation where you can't do it with diet, yeah, I would consider an ACE inhibitor, or that would be what I would do. But one of the easiest things to do is just to increase your water intake.
Mhm.
And a lot of people don't drink enough water. And if you drink 6 glasses of water a day, you can actually help suppress the mechanisms that lead to metabolic diseases. So we did this. It's almost a whole different talk or meeting, but we found that fructose stimulates vasopressin, or antidiuretic hormone, vasopressin. And we discovered that one of the vasopressin receptors is involved in metabolic syndrome. It's called the V1b receptor. We never talked about it in medical school because no one knew what it did, but it turns out that there's a receptor that drives cortisol production and glucagon. And these turn out to be very important in metabolic syndrome. And then, of course, it also binds other vasopressin receptors that drive up blood pressure, like
Yeah.
V1A. So it turns out that when you eat sugar or salt, you're activating this pathway, and vasopressin levels go up. And the vasopressin is actually involved in both the development of metabolic syndrome and raising blood pressure. So hydrating turns out to be protective, and we protected animals from sugar in Western diet by just increasing their water intake. It
Yeah.
wasn't 100%, it was partial, but it was significant. So I would say, um, everyone should drink 6 to 8 glasses of water a day. And you don't want to drink 25 glasses because you can actually, um, you know, get toxic from drinking
Yeah.
too much water. You can dilute your osmolality if you outdo your ability of your kidney to get rid of water. And so, but 6 to 8 glasses of water a day is just so healthy and so good. So one of the first rules is just drink a glass of water before each meal. When you sit down to a meal, ask for a glass of water, drink it if you can before you start eating, and it
Mhm.
will help reduce any rise in salt concentrations and all that. And at the same time, it will hydrate you. It's good for you. Um, yeah, that's what you should.
Can hypertension induced by exercise, um, that, for example, if someone does high intensity or moderate intensity and he's borderline hypertension and the blood pressure starts to spike to 180 or 200 systolic or 220, and then he stops the exercise and the blood pressure goes down, does that spike cause organ damage or endothelial damage?
That one, no one knows, but I've seen a lot of people say, don't worry about a blood pressure spike during exercise. But personally, so here's what I do know. I know that when I take an animal and I raise the blood pressure to that there's this magic transition point. So when I raise blood pressure in a animal, what happens is the blood supply to the kidney, what we call the arterioles, the afferent arterioles constrict. And this is an auto-regulation that helps keep the blood pressure in the kidney normal. So the glomerular pressure is protected from a surge in systemic blood pressure by this mechanism. But when you get around 170 in the rat, suddenly the vasoconstriction is not enough, and they start getting high pressures in the kidney that cause injury. And you can absolutely show that there's a cusp around 170, 180, where high blood pressure causes really active injury. That doesn't mean that lower blood pressures don't cause low grade injury, but I'm talking about significant injury. So I have always lived thinking, and actually in people, we know that when your blood pressure is like 180, it's like a malignant type of
Yeah.
hypertension often. It's often associated with much more organ damage and progression. And in the 1950s and 1960s, when everything was kind of observational, they really could show that there was this link between this cutoff of like 180 and kidney damage. So if you're exercising and you shooting your blood pressure to 180 or higher, that bothers me as a physiologist. I know that many physicians say, well, there's no evidence that, you can do bad things, but I think you probably could. And especially for God's sakes, if you have like an aortic aneurysm or something like that, and you take your blood pressure to 180, 200, I think everyone would say, don't exercise to that level. A lot of people don't measure blood pressure while they're actively exercising. So
Yeah.
we don't really know how many people are in this category.
Yeah. You tend
I
to
don't
see
think
it.
it's I don't think it's as high as we think, but if
Yeah.
you are in that category, I would probably take an ACE inhibitor. We know that people who are super athletes can get cardiac hypertrophy, right?
Yeah.
So yeah, I think yeah, I'm more of an experimentalist than a clinical hypertension specialist. But
Mhm.
I would be cautious if you told me that that you love to exercise every day and your blood pressure shoots up to 200 during exercise, and you were my patient, I would have you on a ACE inhibitor or angiotensin receptor blocker for sure.
Yeah. The thing is, we see it very often in the treadmill testing. When we do the treadmill testing and
There you
we
go.
measure one of the criteria is to see the blood pressure. Many people, their blood pressure spikes very high. It's not very uncommon, especially with people
Okay,
with
so maybe
borderline.
it's more. So you know from experimenting or from personal experience. So
Yes.
what do you do? How do you feel about it? I mean, the classic teaching is you let it go, but what do you do?
You put them on a 24-hour blood pressure monitoring
That
and
makes.
just let them monitor and tell them to do mild to moderate exercise.
I mean, I think you're right. I don't think that like they used to say, running is always a great sport. Well, it is a great sport. But there are a lot of marathon runners that will run to the point that they get muscle breakdown and they can get acute kidney injury and they can get all kinds of issues. And, um, you know, women who become very aesthetic from running can lose their ability to menstruate and things like that. So,
Yep.
I mean, it's a great thing, but you can probably overdo it.
Yeah. Yeah. Anything in excess is not good. I- If
Probably right.
if you had to hypothesize what is the organ that has the lion's share of hypertension, is it a centric problem? You talked about the sympathetic nervous system. Is it a kidney problem? What would you say has the lion's share of hypertension cause?
I think it begins with the kidney. And I've written a lot about this. We think that it begins with anything that causes vasoconstriction to the kidney starts the whole process. And, certain drugs like cyclosporin cause vasoconstriction of the kidney, it can cause hypertension. So sympathetic, if you get excited and your sympathetic nervous system's activated, you'll reduce blood supply to the kidney. Anything that reduces blood supply to the kidney by 40% or so will will trigger a hypertensive response. And then what happens is over time, there's a inflammation that develops in the kidney from the ischemia, from the repetitive reduction in blood flow. And that ischemia is associated with an infiltration of inflammatory cells. And those inflammatory cells continue releasing substances that maintain the vasoconstriction to the kidney. And once that happens, what it does is it reduces the ability to excrete salt, and the sodium levels go up in the blood. That triggers the systemic responses that lead to vasoconstriction of blood vessels and everything. So the whole thing is kind of tightly woven, but it begins,
In the
I
kidney.
believe it begins in the kidney. Our work really suggests that. So we think hypertension is really a kidney issue initially. Now you can have other mechanisms of hypertension like primary
Yeah.
aldosteronism and so forth that are holding on to salt a different way hormonally as opposed to ischemia to the kidney, which holds on to salt. So
Mhm.
there's other ways you can get to the same endpoint. But yeah,
And can you
yeah.
test for that low-grade inflammation in the kidney or those little bit of that damage in the kidney? Can
We
you test
can't
for it?
yet, but my friend Bernardo did a beautiful study where he showed that it was associated with elevated urinary TNF alpha, and he also, this is in people, and he also measured heat shock protein reactivity in the blood, and in people with uh, this type of hypertension.
Like,
And then he also did a study where he blocked inflammation in people. And when he blocked the inflammation, blood pressure came down. So others have shown this now too. So we now know that blood pressure, we were taught for 100 years that blood pressure is really a vascular hemodynamic problem. It's constriction and dilation. It's a constrictive disease, right? And vascular resistance goes up. So we're always thinking about hormones that drive vascular, uh, you know, relaxation or constriction, angiotensin, sympathetic nervous system. But what we're now learning is that there's also an inflammatory mechanism associated with hypertension.
mhm.
And so the inflammatory system seems to drive the vasoconstriction. Maybe not initially, because there are substances that will cause vasoconstriction and drive blood pressure, but to get persistent hypertension, you need this inflammation component. And there's now hundreds of papers on this, and we were some of the early investigators that kind of noted this inflammation pathway. Probably, yeah, one of the earliest.
And you said he blocked inflammation. How did he do that?
With mycophenolate, he
Mhm.
took people with psoriasis who were going to get mycophenolate anyway, and he found that they had essential hypertension. And he had them, on stable blood pressure medicine where their blood pressure wasn't well controlled. And when they put them on MMF for psoriasis, the blood pressure fell, and so did the inflammation markers in the urine. And then when he stopped the MMF, the inflammation came back and the blood pressure came up.
Is there non-pharmacological way or uh, supplements or some medication with hypothesize that lowers the inflammation of the kidney safely and that will drop blood pressure? This is, of course, not research, but just a hypothetical question.
I'm sure there might be. A lot of people trying flavanols. We have some people trying things like curcumin, and um, you know, uh, I can't I can't specifically argue for any one right now. Not, but I bet you there's some.
And this is related to um, renal autoregulation. You spoke about this
Yeah.
before. That the renal will have autoregulation defect.
Yeah. So what happens also is that as you develop hypertension, um, you do get altered autoregulation, and you get matrix deposition in the arterioles. And that's associated with a lesion that you can see called arterial sclerosis. And when there's the arterial sclerosis is in the kidney, it's almost always associated with hypertension. There's even a guy, a pathologist, who's developed a way to predict or to tell you what your blood pressure is based upon looking at a biopsy of the kidney. So he did a study where he could develop a formula for kind of predicting your level of hypertension by looking at the level of arteriosclerosis in the kidney. But I know you in the early phase you can have pretty significant hypertension with mild arteriosclerosis. So the arteriosclerosis does worsen with length of hypertension as well. So I don't think his formula is quite so good, but it is true that hypertension, persistent hypertension is really linked with arteriosclerosis in the kidney, and those microvessels are constricted and they're driven by the inflammatory response. And the data is pretty strong now.
Yes, and you would
like hundreds of papers.
And you wouldn't necessarily detect the the arterial issue with the renal angiography. It could be completely normal.
Right, probably, yeah, because it's really at the microvessel. Yeah. But people with hypertension will have reduced renal blood flow. So if you do like a nuclear scan, you can show that there's a relative reduction in renal blood flow, what we call high filtration fraction. Oh wait, let's see. Yeah, because the filtration fraction is the GFR divided by renal blood flow, and as renal blood flow falls, the filtration fraction goes up.
This is why would some people have higher response or overactive sympathetic nervous system?
I do know that there is a kidney-brain sympathetic nervous system connection, and when you like eat salt, or when you get that ischemic response in the kidney, there's a reflex sympathetic activation of the brain that Vito Campisi and some other researchers showed, so that there is this kidney-brain CNS sympathetic connection. And then, the sympathetic response probably has many things modulating it, environmental, genetic, lot of factors. But it is absolutely true that some people have a more pronounced sympathetic response. Other ones can, faint when their blood is drawn, and others will develop hypertension. And I haven't studied that, so I'm not a sympathetic nervous system person, but I think that the variability is well known. So
hypertension is very complicated disease. So many organs involved, so many hormones. From your decade of research and experience, what is the best explanation for hypertension, and what are some of the mechanisms that are overlooked?
Well, the current idea is that hypertension is a multifactorial condition. There are very many systems controlling the cardiovascular system and blood pressure, which are activated in hypertension. And for some of them, there is a sort of a positive feedback interaction. For example, insulin stimulates the sympathetic nervous system, and the sympathetic activation increases insulin resistance, and therefore it increases the insulin level, just to mention one. But another interaction is between the renin-angiotensin-aldosterone system and the sympathetic nervous system. Sympathetic activation is responsible for production of renin from the juxtaglomerular cells, and in turn, angiotensin II has a stimulating effect on the sympathetic activity, both at the level of the brain and at the peripheral nerve terminations. So you see, it's difficult to identify, except for a small number of conditions. Secondary hypertension is different to identify specific mechanisms responsible for the development of hypertension. This has an important practical implication, and this is that efficacy of treatment is largely related to combination of drugs with different mechanisms. This is, in a way, a reflection of the multifactorial conditions that are responsible for the generation of a high blood pressure.
You have done a lot of work, mainly the most famous is the Pamela study to establish that white coat hypertension is not a benign condition. Could you talk to us about white coat syndrome and what is the reason or mechanism behind white coat syndrome, if we know a reason for it?
And this is a very interesting question to discuss because white coat hypertension is extremely common. Maybe 30–40% of the hypertensive patients do have white coat hypertension. In the elderly, even more than 50%. In the HIVET trial in people age more than 80 years, more than 50% of the patients had white coat hypertension. Yes, what you say is absolutely true. White coat hypertension is not an innocent clinical condition. And unfortunately, this has to be said and said and said again, because many people believe that diagnosis an individual as having white coat hypertension means that he or she has no risk. This is not true. For example, subclinical organ damage is more common in white coat hypertension than in normotension. The risk of developing over the years sustained hypertension or diabetes or new organ damage is greater in white coat hypertension than in normotension. And the risk of having cardiovascular events over the years, we did the study having more than 15 years follow-up in the patients. Well, the risk of having hard clinical outcomes was definitely greater in white coat hypertension than in normotension, although being less than that of sustained hypertension. So it's a condition which is in between true normotension and true hypertension. Why this is so? Well, there are several factors that can explain this. For example, one of them is that although by definition out-of-office blood pressure is normal in white coat hypertension, it is less normal than in truly normal individuals. We define it as normal, but it is still 3 or 4 millimeter of mercury ambulatory blood pressure higher than in normotensive subjects. And home blood pressure is 6, 7, 8 millimeter of mercury higher in white coat hypertension than in normotension, although remaining below the so-called threshold for hypertension. And then, for example, nocturnal hypertension is also more common in white coat hypertension than in normotension. The lipid profile is more commonly abnormal in white coat hypertension than in normotension. So there are many, many conditions that explain why white coat hypertension is not an innocent condition. What is the whole as far as knowledge is concerned in this area? Well, there is an important missing information, and this is that once we have identified white coat hypertension and diagnose it, the problem is what do we do? Do we treat these patients or not? And the answer to this is we do not know, because there are no trials exploring whether lowering office blood pressure in white coat hypertension is associated with a reduction of cardiovascular events. So guidelines, have to deal with this difficult problem, and they have a sort of a compromise. They say, well, if patients have organ damage, then you may consider treatment. If patients have just pure white coat hypertension, follow it more closely, but do not treat. But this is based on clinical considerations, not on evidence.
Do we understand the mechanism behind white coat syndrome? Is it related to the sympathetic nervous system? Is it related to the amygdala, to the afferent vagus nerve, to the renin-angiotensin-aldosterone system? Or what is the reason behind white coat hypertension?
Well, is not clear. One of the reasons for sure is reactivity to the doctor's visit. That could be one of the reasons, but not the only reason, because we do have not really close correlation between patient's reaction to the emotional stress of the doctor visit and the existence of white coat hypertension. My colleague, Professor Grassi, working in Milan, has shown several years ago that sympathetic activity, as measured by microneurography, that is directly quantifying the number of sympathetic bursts in humans at the peroneal nerve level, well, sympathetic activity is greater in white coat hypertensive subjects than in normotensive subjects. So the cause of white coat hypertension is not limited to the mechanism of the blood pressure increase during the doctor visit, but it is something different and more systemic.
Mm-hmm. Do we have understanding why oversympathetic nervous system is in some people, and why would some people respond to stress? Their blood pressure would spike and respond to stress than others?
No, I don't think that this is known, unfortunately. But we do know that laboratory stressors, for example, say mental exercise, isometric exercise, for example, hand grip, or dynamic exercise, for example, treadmill, all laboratory maneuvers that increase blood pressure, they do not have a correlation to one another. We did these studies many years ago when we were doing intra-arterial ambulatory blood pressure monitoring, so we could do a number of things which are normally unavailable to current research because of inability to measure blood pressure intra-arterially in physiological conditions. Well, there was absolutely no correlation between response to one laboratory stressor and response to another laboratory stressor. So it is very difficult, therefore, to give a general meaning to responses to stressors in subjects and approach the problem you mentioned, that is, what is the nature behind the responses to stress in a way. But one other thing we found is that responses to laboratory stressors do not correlate with blood pressure variability throughout the 24 hours. You see, this is another puzzling thing. I mean, you can be hyperreactor to one stressors, but not to the other stressors, and not to overall blood pressure variability, which is probably generated by a number of factors well beyond just the emotional response to stimuli.
And the overactive sympathetic nervous system is a centric problem, or do we know any pathophysiology about it, or what causes it?
Well, one central factors are certainly involved, for sure, but there can be other mechanisms. One of the possible mechanisms, for example, abnormalities of the baroreflex.
Mm-hmm.
Baroreflex normally keep sympathetic activity down. People with denervation of the carotid and aortic baroreceptors do have sympathetic activation because these inhibitory mechanisms are not functioning. However, this is an acute mechanism in a way. If we keep animals with subaortic denervation and leave them free, unrestrained, over the months, blood pressure goes down and the baroreceptor reflex reset in a way down what is left from the baroreceptor reflex. So the current view is more than abnormalities in the baroreflex may be responsible for a baroreceptor reflex resetting, but not so much for the level of blood pressure and sympathetic activity persistently over the day and night in a way. We're dealing with a complicated factor, I'm afraid, and I cannot give you a conclusive response to this. But certainly central factors are involved. There is a hyperreaction to emotional stimuli. Certainly they are involved. Remember that hyperactivity of central factors, they can silence the baroreflex. I remember many, many years ago, in the 70s, we did a study on few people involved. There were the same investigators, myself included, was involved in this story. And this was to see what was the response to hand grip exercise, the pressure response, modified by central factors. That is the brain. That is the will of the investigators to inhibit the response. And amazingly, there was the capability of influencing the response by just thinking of influencing the response. So the brain is involved in modifying a number of more peripheral mechanisms in many ways. But I think going to the practice, I think without the mechanisms, there is no question that in hypertension, sympathetic activity is increased. And the increase can be visible already in the very early phases. For example, children of two hypertensive parents, not children, I mean young people from two hypertensive parents, even if they are normotensive, they do have an increased sympathetic activity. And then the increase in sympathetic activity is further enhanced as hypertension progresses. The severity of hypertension is associated with increase in sympathetic activity, and the highest level we have found is in resistant hypertensive patients.
Do we have any understanding about the baroreflex, what the pathophysiology is behind it, or understanding how it contributes to sympathetic nervous system? Is it because of inflammation, because of genetics, because of any known factors?
Well, first of all, no question that afferent fibers from carotid sinus and the aortic arc, they do have a strong inhibitory influence on reflexly on sympathetic activity. That's for sure. I mean, if they are cut, the sympathetic activity goes up and blood pressure goes up markedly. So the main action of the baroreflex is to provide homeostatic mechanisms again to marked variations in blood pressure. There are some beautiful experiments on this. One is in dogs, and the other one is in cats by our group in Milan. And then the other problem is that the baroreflex interacts very markedly with other reflexes. For example, the chemoreflex. Chemoreflex is an excitatory activity. If I stimulate the chemoreceptors in the carotid sinus by hypoxia, ischemic hypoxia, for example, well, there is a striking increase in blood pressure and generalized vasoconstriction, plus bradycardia. This is anomalous, but this is what happens. Well, if I do this stimulation at a high baroreceptor levels, that is in isolated carotid sinuses, I perfuse the carotid sinuses by anoxic blood, and in the meantime, keep the carotid sinus pressure at 200 millimeter mercury. That is maximal baroreceptor stimulation. What happens? Chemoreceptors do absolutely nothing. That is, they lose their control of the circulation, presumably because they are inhibited at the central level. Baroreceptor influences are capable of silencing the central influence of the chemoreceptor reflexes. Now, more recently, this was found to give an explanation to the fact why in resistant hypertension in humans, when we stimulate electrically the baroreceptor afferents, and you see that this one is one of the tool which is used in emergency to reduce blood pressure, resistant blood pressure, or in emergency conditions in which blood pressure can be markedly elevated. Well, this can be explained because electrical stimulation of the baroreflexes can prevent the simultaneous vasoconstrictor effect of the chemoreceptors. Otherwise, you wouldn't know, because the electrical stimulation of the afferent fiber stimulates both chemoreceptors and baroreceptors. But what prevails is the baroreceptor stimulation.
Do you believe that white coat syndrome also is not just in the hospital settings, it's also from day to day, from while working, while driving, while dealing with everyday stressors?
Absolutely, absolutely. It's not only in hospital. I mean, I mentioned this 30-40% prevalence of white coat hypertension refers to the general population, not to the hospitalized patients. And what we look at this in detail when we were doing intraarterial blood pressure monitoring, and what we asked physicians was to go and measure blood pressure when blood pressure was measured intraarterially in the patients for 48 hours and what we found was that the reaction of the patients to the doctor visit was very common, sometimes a striking effect. In one patient, I remember, as the doctor entered the patient's room, and the patient had an intraarterial line, of course. In the intraarterial line of the patient, there was an 80 millimeter of mercury increase in blood pressure. And I'm not talking of hospital. I'm talking of people in their
Outpatient.
Yeah, outpatient. And then the visits were repeated, and up to 4 visits, the response was more or less the same. So there was this. You may think that the second time, they adapt to the blood pressure measuring by the doctor. But as far as we can see, this stress-related emotional response by the patient was preserved.
When the blood pressure initial reading is very high and then the second one comes normal, it fluctuates so much variability between few minutes of reading. Is that also related to the same mechanism?
Yes, it is related to the emotional effect of blood pressure measurement. We could see in the intraarterial tracing very clearly the peak response came after between 30 seconds or 1.5 minutes after the beginning of the visit. And then there was a gradual reduction so that at the end of the 15-minute visit, maybe 1/3 of the pressure effect was still there.
Mm-hmm.
And then we look in another study in which there was a randomized measurement of blood pressure by a doctor and a nurse in the same patients, 30 patients, I remember. First, 15 times the doctor visit was the first, and then the nurse's visit, and in the other 15 times the sequence was reversed. And no question that the blood pressure rise was less with the nurses than with the doctor, about half.
Do we know at which level do we get endothelial damage or organ damage? At which level of spike in blood pressure?
No, I do not know, but of course it is very well known that endothelial function is adversely affected by blood pressure elevation. I think there is also evidence that this adverse effect occurs rather early in the course of hypertension, but I don't think that the details go much further than this.
At which level do you start to think that maybe it's wise to go more aggressively with these people with white coat syndrome or people who have spike to blood pressure to stressor? At which level do you start to think maybe pharmacological therapy is justified at those cases? Is there a threshold or a level where you get more aggressive than conservative to wait till an organ damage occurs?
No clue about this. As I mentioned before, guidelines limit themselves to the recommendation to identify, if possible, whether a patient has white coat hypertension, because of course this means a greater risk than in normotensive patients. But then as far as treatment is concerned, it's rather vague because of the absence of evidence. And therefore, what I say is to follow the patient more closely and to try to give antihypertensive drugs if there is organ damage or a number of other risk factors, you see. But this is based on what we can consider medical common sense, but no more than common sense. I would add two considerations on this very difficult aspect of medicine, particularly in the area of hypertension. And the first is white coat hypertension was common, for sure, in many trials which showed the beneficial effect of treatment. In the HYVET trial, for example, we know that white coat hypertension had a prevalence of more than 50%. And in HYVET, reduction in blood pressure was associated with a clear-cut reduction of cardiovascular events, particularly heart failure, but also stroke. Well, my question is, would this be possible if white coat hypertensive patients did not participate in the benefit? Being so common, you see. And this is an argument in favor of treating white coat hypertensive patients. Of course, the best solution would be to have a trial in which we can recruit white coat hypertensive patients and have a control group without treatment and a treated group. The second point is more delicate, and this is suppose that we decide in a way to follow the guidelines and we do not treat a white coat hypertensive individual. And suppose that, unfortunately, this patient has a stroke. Now, this could pose a legal problem because lawyers could say, well, why didn't you treat this patient when there is evidence from trials on more than 500,000 patients that lowering office blood pressure is associated with protection? A big protection against stroke. So why did you avoid treating? And then we have to say, well, because, white coat hypertension guidelines say that we shouldn't treat them. But I think that would be a very difficult case to be resolved and a big problem for the doctor.
Believe that an agent that works on the sympathetic nervous system
Yes.
lowers the activity of the sympathetic nervous system. A calming agent would lower the sympathetic nervous system, and that will lead to lower blood pressure reading.
No question that if we give drugs acting against the sympathetic nervous system, this is responsible for blood pressure reduction. We can have a number of examples. For example, in the past, this is part of history now, but sympatholytic drugs, were widely used. Guanethidine, for example, to reduce blood pressure. Ganglion blockers were widely used to reduce blood pressure. Beta blockers today they work through reduction of sympathetic activity, which in turn means also reduction in the renin-angiotensin system activity, because reducing sympathetic activity reduces secretion of renin from the juxtaglomerular cells. But I mean, the primary factor is reduction in sympathetic activity. This is widely known. But even alpha blockers, if we give alpha blockers, blood pressure is reduced. One of the problem has been, as far as alpha blockers are concerned, that development of new alpha blockers was stopped because of the unfortunate results of a major trial in hypertension. This was all hat. In all hat, there were 4 different groups treated. One of them was treated with doxazosine, which is an alpha blocker, long-acting alpha blocker. Another with diuretic and so forth. And the doxazosine group was stopped after few years, 2 or 3 years, I do not remember exactly, because compared to diuretic, heart failure, the incidence of heart failure was doubled compared to diuretic. And of course, this has had such a big effect on the thinking of investigators and clinicians in the area of hypertension, that nobody really took the risk to work and develop other alpha blockers. Now we know that probably there was a problem in all hat data, and the problem was that the patients in all hat, before the beginning of the study, were all under diuretic. Most of them, the vast majority of them, was under diuretic treatment. Okay. And of course, diuretic treatment was stopped to randomize the doxazosine arm. Since they were high-risk patients, the reasoning is that probably many of them had, a number of them had heart failure, which was masked by diuretic treatment. And when diuretics were stopped, heart failure appeared, you see. So it was not doxazosine, but it was, in a way, a sort of an artifact due to stopping a drug masking the symptoms of heart failure, which was the diuretic. And this hypothesis is, in a way, supported by the fact that despite the much greater incidence of heart failure in the doxazosine group, there was very little difference in mortality in these patients with heart failure. So it was a heart failure which didn't have the usual high risk of death, which normally heart failure has. But anyway, the long-term effect of this study was that alpha blockers are not used in heart failure. Alpha blockers are used in hypertension to lower blood pressure, but only as a second or third or fourth drug, not really one of the major antihypertensive drugs.
Is there any agent that lowers the sympathetic nervous system but does not cause bradycardia? So if someone has bradycardia and white coat syndrome due to being an athlete.
Yes, of course. And the example is, again, doxazosine, alpha blockers. Alpha blockers do cause tachycardia because of reflex, baroreceptor reflex mechanism. Reduction in blood pressure, and the baroreflex works to increase heart rate. So they were normally given with a beta blocker.
And there is another agent called riflexudine, I believe. I don't recall the name exactly now, that has minimal effect on the heart rate and lowers the sympathetic nervous system.
Yes, but for example, there are also the so-called central agents. One of them was widely used in the past, and this was methyl-dopa, but even clonidine is a central agent with a clear-cut blood pressure lowering effect. It's still used in hypertensive emergencies today, like methyl-dopa. Methyl-dopa is still one important drug to treat hypertension in pregnancy. And both of them do have a bradycardic effect, but this is a very, very small. Could be 2 or 3 beats per minute, not more than this. Certainly much smaller than what you can see with beta blockers.
And there is one agent, let me just rilmenidine.
Rilmenidine. Yes, this is a central agent and working through mechanisms somewhat different from those of methyl-dopa and clonidine, through blockade or stimulation, I do not remember exactly now, of receptors which are different from the other 2 drugs, but still belonging to the group of central agents and more or less with similar effects as methyl-dopa and clonidine.
Bradycardia, or very less minimal than the others?
No, it's more or less small bradycardic effect. I mean, but really the reduction in heart rate is very small. I mean, reduction in heart rate when it is limited to 7-8 beats per minute, this is more or less the effect of beta blockers. Could be 10 beats per minute, but normally we are in this range. This does not represent a disadvantage, okay? Because heart rate is a very clear independent cardiovascular risk factor, particularly above 80 beats per minute. So lowering heart rate is not regarded as an adverse effect in general. There has been a paper published just few days ago in the European Heart Journal. Is a meta-analysis of trials having a reduction in heart rate, more than 2 beats per minute. Very huge, 74 trials. I'm a co-author. No. And it shows that on average, a reduction of heart rate of 80 beats per minute is associated with reduction of cardiovascular events. And of course, this study was done by adjusting for blood pressure changes, and it was also done using trials with negligible effects on blood pressure.
The challenge becomes when someone is bradycardic and their heart rate is around 60 of their athletes, then that would be
right. I think in this meta-analysis, for example, what was found was that the advantage was visible, particularly if heart rate remained between, during treatment, 65 to 70 beats per minute. Below 65, the advantage was less clear. You see, so I think the point you made is a good point. I think the advantage of reducing heart rate may be less in the below 60 beats per minute. Maybe the benefit in this case is not so clear, but still, if I give a beta blocker, I'm looking at other types of benefits. For example, reduction in sympathetic activity and the blood pressure reduction. From the fact that sympathetic nerve activity can be reduced also by blockers of the renin-angiotensin system, okay? Because of elimination of the sympatho-activating influence of angiotensin II.
Like ACE and ARBs? Like ACE inhibitor and ARBs?
ACE inhibitors or ARB, more or less, they have the same influence, although the evidence is stronger for ACE inhibitors. For example, we've seen this in humans in which we measure coronary blood flow and intraarterial blood pressure. They were on the hemodynamic table. And we look at the response, the pressure response to a stressor before and after intracoronary administration of minute doses of angiotensin inhibitor, okay? And the pressure response to sympathetic activation, there is coronary vasoconstriction. These were all, of course, patients with no coronary problems, of course, they were normal. The vasoconstrictor, sympathetic induced vasoconstriction was markedly reduced by minute dose of ACE inhibitors in the coronary arteries.
Very interesting.
This is an example of interaction.
Do you think the same benefit can come from oral ACE inhibitor or ARB, that it will lower the sympathetic nervous system and the blood pressure?
I think so, yes.
If you would do a clinical trial for white coat syndrome and you choose an agent to put in the group, is there a specific agent would you think will work very well in those groups?
No, I think I would use treatment which is recommended by guidelines in a way. Without any, the problem would be to have a common type of treatment, which is a guidelines combination treatment for sure, and then versus a placebo group or white coat hypertensive individuals. This trial has never been done, and I'm afraid it will be difficult to do a study like this because since risk of events is quite low, less than in true hypertension, it will have to be a very, very large trial, big trial, in order to reach the statistical power good enough to support the significance of a difference. And I think this will be very, very difficult to be done. So we are confined to this very ambiguous position that we are advised to try to identify white coat hypertension and the contrary, that is masked hypertension. But in the end, then we do not have any help in terms of what we shall then do as far as treatment is concerned.
Yeah, and the challenge also that for white coat hypertension, it will take them much more longer to get an organ damage or to establish results.
Exactly like this. It will have to be a very large and very long study.
Yes.
And now we know that one of the problems of increasing the length, the duration of the study beyond the 4 or 5 years is that there is an exponential increase in the patients lost to follow-up, patients that say, stop, I do not continue. Sorry for you, but I do not continue. And this, of course, weakens very much the scientific basis of the study. This is the reason why one of the big problems of antihypertensive treatment today is that our evidence, trial-based evidence, is from studies of a 5-6 year duration. But based on this evidence, we advise our patients to take drugs for the lifetime. Okay? But the remaining evidence is based on observational studies, not on trial.
And in your experience, when you decide to treat someone with white coat hypertension, is there a specific agent you would go for, or you would just follow the guideline, whatever? What I'm trying to ask is, do you try to find an agent that works in the sympathetic nervous system on top of hypertension, or you just follow normally what the guideline says? And do you think there is an advantage?
I have to say, I mean, theoretically, because of increase in sympathetic activity, beta blockers could be one of the drugs used. But I have to say that I do not pay too much attention to this. If I decide to treat a white coat hypertensive patient, individual, I think I just try to lower office blood pressure using, one of the 5 major drugs which are recommended by guidelines.
Exercise is very good for hypertension on the long run, and but sometimes when we do like the treadmill testing and so on, when you do exercise, the blood pressure do spike very high. Does that spike in blood pressure, if it goes very high up to 180 or 200, harmful?
We don't know. We don't know because, of course, it's difficult to have enough outcomes to decide that this is dangerous. I mean, based on common sense, of course, one should think that there's something to be avoided. One other thing consideration is that patients showing a very marked pressure response to treadmill exercise have a greater risk of having mast hypertension. So the next thing to do is to have a 24-hour ambulatory blood pressure monitoring in order to see whether these patients do have mast hypertension, because this means an increased risk. Not at the same level as the risk of true hypertension, but definitely an increased risk. But then, of course, the problem is more or less the same as the one for white coat hypertension. That is, do we treat this patient with mast hypertension then? And guidelines do not take a definite position. I think they again say that if the patient has organ damage and so then lowering out of office blood pressure should be considered.
Yes. And also
I think this is probably the best, the most, the best recommendation we can give.
Mm-hmm. And sometimes the diagnosis of hypertension is easy to establish, but sometimes it's very complicated. So sometimes someone would visit the office and will have hypertension, and another visit will not have, but then you will do the 24-hour blood pressure and he will have normal to normal reading. How do you deal with such cases?
Well, which blood pressure shall we use to diagnose hypertension? Okay. Now, according to the guidelines of the European Society of Hypertension, office blood pressure is still the reference blood pressure because all epidemiological data and trial data we have and value the threshold for treatment and the target for treatment, they come from office blood pressure. We have no trials on ambulatory blood pressure. Okay. But then, of course, we say that ambulatory blood pressure is a source of important information. One of them is to identify phenotypes such as white coat and mast hypertension. So anytime this is feasible, data should come from ambulatory blood pressure, should be obtained. But office blood pressure remains the reference blood pressure. So diagnosis of hypertension and the threshold value at which to start drug treatment should remain office blood pressure. This is according to the guidelines of the European Society of Hypertension. The guidelines of the European Society of Cardiology take a somewhat different position. They say that diagnosis of hypertension should take into consideration ambulatory or home blood pressure. Mm-hmm. But there is a little bit of a contradiction then, because classification of blood pressure into non-elevated, elevated blood pressure and hypertension is based on office blood pressure. And the threshold and target for treatment are based on office blood pressure. So in a way, in practice, even these guidelines give preference to office blood pressure, in my opinion.
Do you rely on the first reading of blood pressure? If someone is high, then you wait 2 to 3 minutes and then measure it again. So do you rely on the initial reading or multiple readings and you average it out? Usually when the patient comes in the beginning, the first reading, especially if he didn't sit down, that in many people initially will be high.
And first of all, let me say there have been many studies looking at whether variability of blood pressure within a visit has a clinical meaning. And the answer from most studies is no. Okay. Anyway, it is true what you say. That is, the first reading tend to be higher. And so guidelines, although somewhat arbitrarily, what they say is you should have three measurements. The first measurement 5 minutes after the beginning of the visits, and then other two measurements at 1-2 minutes interval, and then take away the first value and make the average of the last two. This is what is recommended. I think most guidelines do this, and I think it is important that guidelines agree on this because of the possibility to compare data. Of course, the other problem is that particularly in grade 1 and grade 2 hypertension, you should repeat the visit. Just do not take the value at the first visit as diagnostic, but repeat the visit after a few weeks, other two visits. So, I mean, in the end, the judgment should come from more than one visit, except if blood pressure is extremely high or you have evidence of hypertension-mediated organ damage, then you can save time in a way and rely on the value of the initial visit or maybe two visits in order to have a regular visit with the regular blood pressure measurements, because in hospital, values can be completely different.
Tell us, please, a little bit about the PAMELA study that you have followed the I think it was over 2,000 patients for 10 years.
Yeah. It was a branch of the MONICA study by the WHO, and it was a sample representative of the population of a town in the outskirts of Milan, which was Monza, and it was representative for age, sex, education, a number of things. And the initial purpose was to be able to calculate from a proper sample normality of ambulatory blood pressure value, because at that time, normal ambulatory blood pressure was calculated from people coming to visit and found to have not an elevated ambulatory blood pressure, but if they came to visit, there was something suspicious about them. So it was not really a good group to make a comparison from. And so we calculated the normality of ambulatory blood pressure based on an unbiased population sample, okay, from the population. It was the first goal, but since the study had a number of measurements, lipid profile, glucose, many things, uric acid, of course, renal function, and each individual of the study had an echocardiogram. This was, of course, a big effort, but this was the idea. And that's why we have been able to study a number of things, including metabolic syndrome, including many other things. And then the other thing which has characterized the PAMELA study has been that we restudied the same sample 10 years later. This is the weak point of studies on ambulatory blood pressure elsewhere in the world, that they have just one measurement of ambulatory blood pressure. Then a long follow-up of 15 years in which no data have been collected. So you can imagine, how many changes occurred during this time. In PAMELA, there was a second set of measurements, the same procedure, 10 years later. And then there was a third one, 25 years later. This was completed a few years ago. So we now have a quarter of a century follow-up. Of course, in the meantime, many patients died. But we were able then to have long follow-up of our studies with quite a high number of outcomes. In the recent follow-up, I think we had quite a large number of deaths as well.
And were you following them up between the 10 years or only just initially and after?
No, this was impossible. I mean, this is one of the reasons why studies with ambulatory blood pressure and home blood pressure have not been done with serial measurements like the Framingham study. Framingham study was perfect because in all individuals from the Framingham town, 5,000 patients, not a big study, 5,000, but the procedure was perfect because they had the serial measurements every 2 years, if I remember correctly. And this has been impossible for studies with ambulatory or home blood pressure because inability to have compliance by the individuals if this procedure was used. But at least, I mean, having data 10 years later allow us, for example, to see that in white coat and masked hypertension, the risk of diabetes and the risk of true hypertension was greater than in control subjects.
Do you believe that any of the smart devices that are now they're coming up with smart devices to monitor the blood pressure, do you think those will have value in measuring blood pressure? The continuous measurement.
A continuous measurement, well, I think they should be validated, first of all, and most of them are not. And secondly, I think conditions have to be standardized. Really, at the moment, I think it's a rather chaotic situation with these app devices and things like this. And I'm afraid that there will be serious disadvantages as far as solidity of the diagnosis of hypertension and the precise assessment of the effect of treatment. So I think potentially they can help, but they should be validated, and they should, I mean, we should find a way of standardizing this approach.
Are there any upcoming, other than the 24-hour blood pressure machine devices that will be continuous and without the cuff inflation and deflation, and it will be...
Yeah, the cuffless devices.
Yes, yes.
Yeah, this is quite promising, seems to me, because of course inflating the cuff can be disturbing,
yes, especially in sleep.
Annoying to the patient, particularly
in sleep
during the night. But I'm not sure that this problem, maybe it has been inflated a bit too much, because when we were doing intraarterial ambulatory blood pressure, one study we did was to have non-invasive cuff blood pressure, automatic blood pressure on one arm, intraarterial on the other arm, and we prolonged the intraarterial recording for 48 hours. And 24 hours were done concomitantly with the non-invasive automatic ambulatory and 24 hours without. And the falling blood pressure at night was almost superimposable in the two conditions. So patients could sleep well anyway.
Yes.
But of course, this was the case in our 20 patients. Maybe some patients really, they become sleepless if the cuff inflates regularly and periodically. So I think because of this, cuffless devices, represent a potential advantage, and I think they should be seriously validated. But if this is done, I think it could be a progress.
So many patients, when they increase their intake of potassium and reduce the sodium, that helps in blood pressure control.
Increasing potassium has an antihypertensive effect for sure. And not only an antihypertensive effect, but a protective effect on vital organ structure and function. This has been discovered a long time ago by a famous American investigators from Minnesota. I can't remember the name now, but it was a very important scientist, and he showed wonderful evidence that this is the case. And for this reason, now increase in potassium intake is one of the non-pharmacological based treatment of hypertension. Mm-hmm. In practice, it means eat vegetables. as much as you can.